Okay, Tracy, are you there and ready for our Q&A? Our doctors are all lined up there. We need to get Dr. Nativi back, but everyone else is here. And look, they're ready to answer. I can see Celestial just waiting to get a nutrition question there. So, and I'm so proud of you, Dr. Havasi. I saw you typing away on all those answers, and we really appreciate that. Thank you so much.
I try to answer the questions as they came in.
Bless your heart. You're wonderful. Thank you.
All right. Yes, so we are ready. And actually, you mentioned Celestial. So actually, I want to start with you because we haven't heard. I want to ask some questions to the panelists that didn't present, you know, to give some opportunities there. So okay. I have one.
I first want to say, can you hear me okay?
Yes.
Mm-hmm.
Okay, great.
Yeah, awesome. So my questions are over here, just so you guys know. I'm
okay.
Just looking. Okay, so it says, and most of these I'm just going to read as they came in. As you guys remember, we had submitted, the questions were submitted ahead of time. We have 50 or so plus. I will ask a doctor before I read the questions, so you guys will be able to prepare because we have a lot of people. So it's maybe not easy to listen to all, and we still have the Q&A questions coming in. So if you guys can also still take a look at that once in a while. All right, so the question is, can the guest dietitian offer a menu suggestions for patients on a renal diet that are not on dialysis? As nutrition is important and it's a challenge at home and when socializing. I often have to avoid foods at gatherings, either bring my own or eat before. What are some good party foods I can make / bring? What can I bring for myself that travels well besides the old peanut butter and jelly or a bottle of Ensure?
So in the interest of time, that was a really good question, but also we could talk a lot about that. I am happy to take whoever asked that. I would be happy to get your phone number and talk to you more on the phone. The short answer is I could provide through possibly Muriel a good overview of the renal non-dialysis diet with menus. And then for specifics for party foods and things like that, a website I often refer to, and I'm not affiliated with this group or get paid by them or anything, but it's called davitadialysis.com, DAVITA dialysis. They have an enormous recipe section and they have cookbooks. So that's
maybe you could put that website in the chat box to like all panelists and attendees kind of thing. Yeah.
Sure.
Okay. Awesome. And then, okay, so then you'll work with Muriel and we can get that out there so people can use that. Awesome. So the next one I have is for neurologists. We haven't heard from our neurologist yet. So Dr. Karam says gabapentin was prescribed for peripheral neuropathy, but immediately had to discontinue because even small doses, 100 milligrams, severely exacerbated swelling in my feet. Are there other options for peripheral neuropathy? That's not easy to say, by the way. I think we
peripheral neuropathy. Yes, thank you for the question and excellent program. Thank you for all the speakers and for Muriel to be facilitating this. Gabapentin is one of the most common treatment we use for peripheral neuropathy just because the side effects are present, as you can see, but usually most people tolerate it well. I tried it 100 milligram once and it gives me horrible headache and put me to sleep right away. So I don't like it, but I still prescribe it to patients because a lot of patients like it. There are other options, obviously. Cymbalta or duloxetine is one of my favorite. It's an antidepressant medication, but it also works great on pain. If that doesn't help, nortriptyline is another medication. It's also an antidepressant. It is sedative, so you have to take it in the evening. If the pain is just limited to the feet and you don't want to try something that causes side effects systematically, you can try lidocaine cream, about 5%, and that can, lidocaine is like the Novocaine that the dentist inject in your teeth to numb it. So basically it will calm down a little bit the feet. There are also a lot of different other options that we can try, but these are the ones that I usually try first. And if these don't help, then I would move to something different.
Wonderful. Okay, thank you. The next one, let's talk about cardiology. So perhaps Dr. Wolinsky. We have a question here. It says, can you explain the cardiac biomarkers troponin T and I and BNP and NT-proBNP? Common questions. It says, and additionally, it says, I read on the AL Facebook group that I struggle with some of these medical name, the drug names, but Remodulan is used to reduce heart wall thickness. Is this drug used with amyloid patients? I read that several medical centers observed that a significant percentage of COVID-19 fatalities were people with hypertrophic cardiomyopathy. And would you think there might be greater risk for amyloid patients with thickened heart wall? So a lot in that question.
All right, so what time do we have till? Because this person, again, I'd be happy to talk to them. Let's start with the easy stuff first, and let's go to the end. Hypertrophic cardiomyopathy and amyloid, it does not appear that we're seeing an increase disproportionately of our patients in the hospital with COVID. That said, obviously, patients with both AL and TTR need to really stick, as the other speaker said. I mean, social distancing, be very careful, masks at all time, avoid people who aren't masked, and don't take any chances, because if you are sick, just because you have underlying heart disease, you are at risk. The BNP and the troponin is a little bit complicated, and it's a little complicated also because they're interpreted differently in AL and in TTR. Troponin is a marker of cardiac injury. We can measure a troponin N, or we can measure it at troponin I. BNP, or NT-BNP, which was shown on one of the slides, is a marker of increased pressure, increased stretch on the heart. Both of these are a reflection of the infiltration of the disease by amyloid fibrils and the cardiac decompensated associated with this. So in general, the higher the troponin, the worse the prognosis. The higher the BNP, the worse the prognosis. If the numbers tend to get worse, it would suggest that the disease is stable, not necessarily getting better. If the numbers get worse, it tends to mean that the disease may be progressing, particularly if the symptoms go in the same direction as the biomarkers. People say, well, you know, I feel terrible, but the BNP is better. I'm not sure that means anything. So it really has to be interpreted within a clinical setting. One of the things about amyloid, at least from a cardiology point of view, is what you see is what you get, and you're really looking at the patient and how they are. It's much more important than what the ejection fraction is, or what the BNP is, or what the troponin is. I left out the middle question because I'm not sure what you were asking there, Tracy, about whether it was Remodulin or Remlivid.
Yeah, it asks if Remodulin is used with amyloid patients.
Yeah, so it really is not being used certainly with TTR patients, or as far as I know, with AL amyloid patients. But if anybody else wants to answer that, certainly they can. But we've not had any drugs that really regress the thickening. Ironically, some of the things that we've seen in TTR are some of the drugs that are approved for TTR neuropathy seem to have some early signs that they actually may regress the thickening of the septum a little bit, but they're small early studies.
Thank you. Okay, so I want to move to hematology now. So perhaps Dr. Rosenbaum, I have a question about lungs, that the amyloid in the lungs is perhaps a little rare, but the question is, one of my lung nodules recently turned into squamous cancer, cell cancer. Luckily, it was seen early, and I had open lung surgery at Mayo in Rochester, And the question is, am I going to see this happen again? I have many nodules in my lungs, and is this more a probability than a possibility?
Okay, so two parts to that answer. The first is the typical pattern of AL amyloidosis involving lungs, and that's differentiated somewhat between localized amyloidosis and systemic. In systemic amyloid, I'll stick to that. The typical pattern is both lungs, lower interstitial, what we call an interstitial pattern. So, and that's because amyloid's in the capillaries, the very small blood vessels. And so this mostly looks like we call it interstitial pattern. It looks like a whitening and a fine whitening in those areas. It does not look, we don't typically see in systemic amyloid a nodular pattern or a solid nodule. When we do see specific nodules it's more in the tracheobronchial tree, and we call those amyloidomas, and that's a little different than what we see in patients who have systemic amyloid with lung involvement, who almost always have cardiac and kidney. It's usually not their only organ, so clinically it really does make sense in that context. The second part is a nodule that it looks like had been followed in this patient by probably CAT scans over time. You know, I don't know if this patient has AL, but most nodules, the bigger concern is a lung malignancy, squamous cell or non-squamous cell. So I assume that their physician, a pulmonologist or primary care, have been following this nodule, and as it grew, they were concerned. And amyloid nodule should not typically grow quickly. I mean, amyloid, again, the localized variant can grow more gradually over time. So anything growing quickly as a nodule, I would be very concerned about an active lung malignancy or a metastatic malignancy to the lung from another solid tumor. So they did the exact right thing. They probably did a resection and found that it was squamous cell carcinoma, I'm assuming, of the lung. So,
yeah, I didn't know how to say that word, but that's what it looks like. Yeah, the question said that the lung module had the squamous cell cancer that was removed. Yeah.
But amyloid is always in the differential, especially if someone has amyloid. The radiologist or pulmonologist will always question, could this be an amyloidoma? Could this be amyloid? And we can see nodules that are amyloid in the lung. But again, the differentiation would be, they wouldn't be quickly growing over weeks to months typically.
Okay. Okay, thank you. And Bob, from a registry perspective, this person also asked to include this in the registration. I'm not sure which options we have as far as, when they're picking the involved organs, if we have lungs in there. So something to check.
Yeah, we will. I believe we do, but we'll check on that and make sure that we do incorporate it. Okay.
Okay, back to Celestial, another nutrition question. This was a very general one too, and you may have a similar answer or perhaps some other resources, but it just asks about a good diet for amyloidosis where you have GR, heart, and skin problems. So skin we haven't generally talked about before, so I don't know. Do you have some thoughts?
Yeah, so there is no proven specific diet for amyloidosis, but we do know that a general healthy diet is incredibly important for outcome and health. And so a diet that includes lots of whole grains, fresh fruits and vegetables, lean proteins, as well as healthy fats is going to be the best diet for you. On the flip side, the things to avoid are things that are not good for our bodies, including our heart, and including things that are generally pro-inflammatory. I know that's can go down a rabbit hole of some things that aren't evidence-based, but certain foods just aren't good for the health of our bodies, and that would be high saturated fat diets, high trans fats, greasy, fatty, fried foods, and then high sugar diets. Was there another part to that question that I
don't believe so. It was GI, heart, and skin.
GI, heart, and skin.
Yeah.
And then for each specific one, parts of that, there might be individualized things that could be beneficial. like for instance with GI involvement, like was mentioned earlier, that weight loss can be an issue. And so kind of individualized tailoring to the individual's needs is also really important.
Okay, thank you. Let's move to back to hematology. Perhaps Dr. Kovacsovics.
Kovacsovics, no, that's fine.
Ah, darn it! I practiced it, but not enough.
I can give you a private lesson.
So the question is there a process to determine the stages of amyloidosis? So we talked about it, Dr. Havasi talked about it related to kidneys, but in general for the stages of amyloidosis, are there stages of amyloidosis like there are for cancer? It says the other part they mentioned is that it's very difficult when you do not know your life expectancy or prognosis for the future. So what are your thoughts?
So the first thing when we had diagnosed AL amyloidosis, and this is really for AL, we need to determine is the disease localized versus is it what we call systemic or diffuse. If it's localized, there is no staging necessary. If it is systemic, it can involve different organs, specifically the heart, the kidney, and the liver. And the outcome really of the disease is really driven by the heart more than by other organs. And so we have some scores which help us identify patients with a good risk and low risk disease, and they are really driven by markers of the heart. And so based on data from the Mayo, we have 3 what we call biomarkers which we use. They 2 are cardiac, the proBNP, which we mentioned, the troponin, which was mentioned also, and then the level of light chains. And if the level of light chains is much higher, then the involved is much higher, and we have a cutoff, then we know that it is associated to a worse prognosis. So if patients have, let's say, cardiac involvement, but have no markers, they have a very low stage. If, on the other hand, patients have high troponin, proBNP, and a high level of light chains, we know they have what is called a stage 4. So patients with a low stage have a life expectancy which is really excellent, and patients with a very high, I would say, with all the abnormal markers, have a life expectancy of about 6 months. So that's the staging which we use, and it is really driven by cardiac involvement. We have a separate scoring system, which was described by Dr. Havasi, but that's really only for renal involvement. And that is really separate from the cardiac one. And what that score really identifies is what is the risk of getting into renal failure and dialysis over time. But the main thing which is really driving the prognosis and the main score, we call it the Mayo score. And again, it has 4 really scores from 1 to 4. And that really allows patients, that gives us a good prognostic score. We can tell patients who is expected to live shorter and longer, but it can also help with the treatment. And patients sometimes with a poor prognosis really can do very well, provided they get a complete response.
Let's let Dr. Dispenzieri throw in 2 cents, because you came up with that staging system, didn't you, Dr. Dispenzieri?
Yeah. I missed the question. I was busy answering the web thing. Sorry.
Well, you know, you're disproving the multitask.
Yeah, I'm not a typical woman, I guess. I can't multitask.
Okay. Well, go ahead. Ask the question, Tracy.
Oh, it was about the stages. There was a question about whether there was a process to determine the stage of amyloidosis like there is for cancer.
Yeah, so it's, you know, it's different in the means because these are just blood tests, whereas often staging for cancer is, you know, you're looking at how much tumor there is, you know, how far is it spread and so on. But using the cardiac blood tests and the free light chain blood tests, you get a really good sense of expectations for populations of patients. For any of these markers and any test, any prognostic factor, it's never perfect for the one patient because everybody's different. So these things give you an idea, gee, should I be worried or not? But it never guarantees a fate per se for a one person. It does, these prognostic systems do pretty well. If you have like a group of 100 people, you kind of can get a gist of how those 100 people are going to do. But you know, there are patients who have what we think of as very high risk disease because their heart is really bad or whatever, and they can do splendidly well. But again, you know, as a doctor and a patient, when you're first there, you certainly can look at the stage and say, look, you know, the odds don't look as good as I'd like, but there's a good possibility that we can still do well. I don't know if that answers the question.
Yeah, thank you. Thank you. Let's, Dr. Karam, let's go back to neurology. So I have a question here, also kind of related to staging or such, but it says, is there a scale for rating neuropathies? How do you determine which neuropathies are due to amyloidosis and which are due to possibly drug side effects? And are there treatments for the neuropathies? Maybe it depends on, you know, what the source is.
Yeah, that's a great question. And there are many different scales that for grading the neuropathy, but they would not necessarily help differentiate, you know, neuropathy from amyloid versus neuropathy from the treatment. So I would not use them to differentiate the two types of neuropathy. Now, of course, there are, if we're talking about hATTR amyloidosis, the rate of progression is much faster than other type of neuropathy, so they may have some use. In regarding of how to differentiate the neuropathy from treatment from amyloidosis, sometimes it can be difficult. Usually we take a careful history to see what really started first and how the patient is responding. So for example, if the patient was diagnosed with amyloidosis, no symptoms of neuropathy, and then they started the chemotherapy, and after a few cycles of chemotherapy, they developed the neuropathy, then usually that gives us an idea that most likely the neuropathy is caused by the chemotherapy. And in general, when you modify the dose or the cycles of the treatment, the neuropathy may start to kind of stop progressing and may even improve a little bit after you stop all type of treatment. Whereas if you have an amyloidosis and you stop the treatment, the neuropathy will continue to progress. Of course, people can do nerve biopsy, for example, which are invasive and just gives us, you know, at a certain time whether there's amyloid at the nerve. And so when we are questioning and we have difficulty kind of differentiating, we may necessarily, you know, do a nerve biopsy. And in regard to treatment, if the neuropathy is caused by the amyloidosis, obviously you need to treat the amyloidosis, and we give symptomatic treatment, meaning treatment just to kind of mask and the symptoms and improve the quality of life for the pain. And none of the treatment that we use are specific, but we just discussed gabapentin, duloxetine or Cymbalta, nortriptyline, etc. These are medication to mask the pain. And of course, you have to treat the underlying disorder that is causing the neuropathy.
Wonderful, thank you. Dr. Abraham, are you, I see you there, but you don't have your camera on. Are you able to join? Okay, I just want to check. I have a nephrology question. So I have a patient who says, I have AL amyloidosis with kidney involvement. My last 24-hour urine results indicated a protein concentration of 4.26 grams per 24 hours, sorry. What can I do independently in addition to my treatment to try to lower the secretion and save my kidneys for as long as possible?
Okay, it's a good question. Yeah, so beyond treating the AL amyloidosis, it depends on what other comorbidities the patient has. We see some patients with diabetes who do have AL amyloidosis. In those patients, you treat the diabetes well. and consider drugs that could help reduce proteinuria. Unfortunately, most of these patients also have autonomic dysfunction with low blood pressures, which precludes the use of ACE inhibitors or ARBs, which can reduce the proteinuria as well. Otherwise, the other general things that we recommend is monitoring the blood pressure, monitoring the sodium intake, avoiding drugs that could worsen kidney dysfunction, and general things like that. Yep.
Wonderful, thank you. Cardiology, so maybe perhaps Dr. Nativi. So we have a question here. This is kind of in the direction of insurance, so I'm not sure what your thoughts are here, but it says, do you know if insurance companies are typically approving drugs like Repatha and Praluent for high cholesterol caused by AL amyloidosis? So they're evidently having some troubles with Aetna.
Yes, it's a big. It's not easy to get approval for the new medications to treat cholesterol. So the answer is it depends on the patient insurance. But for example, here in Utah, when we need a patient to go to any of those medications because they have intolerance to statins or statins are not enough, and we need to move to all of those expensive medications, we send them to one of our physicians that focus on these medications and knows how to get the approval process. So the answer is yes, there's going to be a lot of headaches. The insurance is going to fight it back. It's going to be a big fight, but we have been successful in some patients to get them approved. So it's unfortunately, yes, it's a battle to have with insurance companies, but if you find a champion to do that, you might be successful.
If it's hypercholesterolemia due to nephrotic syndrome, do you think it's imperative to make the numbers look perfect, or just hope that you're going to get a response, I guess?
Right. You're asking about if the lowering the numbers will have an effect on nephropathy?
No. So this is Angela, and the question is, if somebody, it was asking about a lipid lowering drugs, expensive lipid lowering drugs, and so most often, the really bad hyperlipidemia is due to nephrotic syndrome, and
right.
So the question there, it's kind of a different story than if somebody has really bad CAD, coronary artery disease, and needs to have their lipids lowered. And so, again, somebody may have really high lipids, but I often don't aim for perfection if it's just due to nephrotic syndrome, if they don't have other true indications.
I agree with you. I
Okay.
agree. I don't think we're going to be offering these medications if there's a nephrotic syndrome or if unless we really feel like on top of the amyloidosis, there's like severe coronary artery disease with stable angina. So I agree with you. I don't think that we offer these medications up front, but for specific patients that on top of the nephrotic syndrome amyloidosis, they have atherosclerotic coronary artery disease, that will be those selected patients. I agree.
I think a better question is if you've got somebody who's got nephrotic syndrome and that high of cholesterol, I think you need to be aware of the potential that they may manifest coronary artery disease in the midst of their treatment, anemia, things like that, and their risk if you're contemplating things like stem cell and things like that. I think, like with any drug, you're looking at cost benefit, and these are expensive drugs, and there may be some other options instead to try and lower cholesterol and get the risk down to appropriate levels for the treatment of the rest of the disease.
Agree with that.
Great discussion. Thank you, guys. So Dr. Dispenzieri, so I have a question here about DARA. So the husband gets the 90-minute infusion of DARA, and is it possible to switch to the injectable? Is there push, if, again, also insurance related, Is there pushback from the insurance sometimes to do so? And will the patient be able to do the injections themselves? Is the patient doing the injections going to also affect the insurance?
Okay, so in general, the answer is no self-injection here. So that's the easiest part. In terms of the, the insurance and getting the subcutaneous for the AL indication and so forth, again, it was just recently FDA approved for myeloma, and I think it's hard enough sometimes even to get DARA for AL patients. We end up massaging diagnoses a little, and so I haven't tried it yet to use the subcutaneous off of clinical trial. So there may be, I think one can try for it, but again, even getting DARA for AL patients can be challenging, and often, the word myeloma has to kind of be in the chart a little bit. There's increasing data showing efficacy, but there's no label for it, and because it's such an expensive medication, either one, the sub-Q or the IV, insurance people are often eager to say denied because of the cost.
Let me throw in a question here to you, Dr. Dispenzieri. We had heard last year that Janssen was going to push for the FDA for approval, and that perhaps DARA would be the first drug approved for AL amyloidosis, and they were throwing out the fact that it might happen in the first or second quarter of this year. Do you see any hope for that happening this year?
Yeah, I mean, I think that, who knows with COVID if timelines are going to be different for things, but certainly, the top line type of criteria have been seen, will be presented. They are going to, share that with the FDA. So, it's possible. And so then there would be a label actually for the subcutaneous as opposed to the IV, because that's how the trial was done. But right now, as folks may or may not be aware, there literally is not one drug approved for AL amyloidosis. Everything is just kind of borrowing from, the amyloid pool of FDA drugs. And in the case of venetoclax, it's, CLL box, but there's really no drug or treatment for AL that is stamped.
You meant pulled from multiple myeloma pool, and so there are no drugs for AL. So, but you're thinking it might look good for the DARA in the next this year.
There are issues with crossover in the trial, and again, so yeah, we'll see. You never know how the FDA is going to respond. I've been working with them at the ARC, and a lot of conversations, and they're trying to get a better understanding of the disease and trying to really understand endpoints better. And so, I think the Janssen folks have put a lot of energy and effort into, this trial, and they have tremendous interest in seeing it go forward. It's pretty obvious the drug is active in AL, but, these, approvals are based on, you predefine, we're going to make such and such happen, and if such and such exactly doesn't happen, then you're left out in trouble. And that happened a little bit with the Exasamib, so that is not going to likely be FDA approved for AL. That might have been the first drug. So it's really a challenge, but we know that it's effective. One of the problems in the Janssen trial, the Andromeda trial, is a lot of patients crossed over to daratumumab. So, you're not gonna, so although it was kind of placebo plus Velcade, bortezomib rather, supposed to use generic names, bortezomib, cyclophosphamide index, so placebo with the triplet versus DARA with the triplet. Patients, if their doctor wasn't happy with, how things were going, could then just use off-label, daratumumab, and so that is going to affect points. And it, sometimes I think medications are, hopefully this won't be a victim of its own success. I think that happened with Exasamib because so many people wanted to use Velcade and as opposed to the Exasamib, and that kind of hurt that trial. So we'll see, but I'm hopeful because it is a really good drug in this disease.
Thank you.
Okay, so thank you guys. Let's move to the next one. Dr. Havasi, I have a question here about kidney disease. So the patient says, I have remained at stage 3 kidney disease for almost 7 years after amyloid in my kidneys and a stem cell transplant in 2013. Is there anything I can do to improve the kidney function? It's actually kind of similar to the question that Dr. Abraham answered, but maybe you also have some additional thoughts about that.
Unfortunately, it's how long ago was the stem cell transplant? Sorry.
2013, so
it's
7
quite
years.
a long time. So whatever improvement we had, it happened already. So now we just have to make sure that the kidneys are not going to get a second hit. So all the things we heard before, just make sure that, you know, blood pressure is good, diet is good. If someone is diabetic, then the blood sugars are well controlled. So all the common sense things that could protect the kidneys. Unfortunately, we don't have anything specific other than, you know, if there is a relapse, then treating the underlying relapse. Or we mentioned already some medications, blood pressure medications that can decrease protein in the urine and could protect the kidneys, the ACE inhibitors and ARBs. If the blood pressure can tolerate those medications, then they can be tried. Healthy diet, all these things. But there is nothing much more we can add, unfortunately.
Thank you. Celestial, I have another one. This one also is very general. So it says, this is, has anyone determined preventative activities, diets, or techniques that can be taken following diagnosis to prolong remission? So very, very general.
No, there's not scientific evidence that any specific activity or part of your diet will treat amyloidosis. But what we do know is that a good, healthy diet is incredibly important in supporting the health of your body through your treatment and things like that. As I had mentioned before, eating a diet that's really high in variety is incredibly important to make sure you're getting enough of each of your important vitamins and minerals, phytonutrients, as well as adequate protein and calories, and then really limiting the junky kind of foods that we think about, like fried foods, greasy foods, fatty foods, foods that are too high in sugar, so that you're not adversely affecting the health of your body in general and of your organs. As far as, was there a part of this question that had to do with activity?
Yeah, activities, diet, and techniques.
Okay.
Yeah.
So I'm not the physical activity expert, but we do know that physical activity is also incredibly important in outcome, and that what you can do for yourself and within the guidelines of what your doctor says is safe for you, and then maybe also working with physical therapy or what are they? I'm trying to think of what they're called, like a rehab specialist.
Occupational therapy.
Yeah, can be incredibly useful for you, because ultimately, we think about the goal here is to keep our body healthy while at the same time combating the amyloidosis.
Mm-hmm. Mm-hmm. All right, wonderful, thank you. So let's look, so for cardiology, maybe both Wolinsky and Nativi. So here we have a question about Lasix. So used Lasix until it stopped working early on. Have been on Bumix for 2 years now. Seems to be getting increasingly difficult to get the swelling in my feet under control. Getting scary as I'm close to being unable to drive because of the swelling in the feet.
Right. So there are different types of oral diuretics, and we go from Lasix, then bumetanide, and then torsemide in terms of how better they work. usually we start with furosemide because most of the patients respond to it. When we start seeing difficulties with furosemide, sometimes we switch to bumetanide because it has also better absorption. Patients with amyloidosis start retaining fluid in their abdomen, and these medications are hard to absorb. But then sometimes we use torsemide because of the three of them. It has a better absorption, but on top of that, it remains longer on the system. So definitely, we see a patient that with furosemide is not enough. There's a couple of other options that we can do. If a patient comes to us and they have fluid retention, usually we're going to see that patient once a month until we remove all of that fluid, the ankle swelling, and then it's very different. Every patient requires different amount of doses. With diuretics, the response depends on the age, the renal function. So usually takes 1 to 3 months of close monitoring to understand what is the amount of dose and what diuretic the patient needs. But at least in our practice, we start with furosemide. We max out the dose up to 80 or 100 milligrams twice a day. If that's not enough, then we switch to torsemide. Or Bumex or bumetanide. On torsemide, we max out at around 100 twice a day. And then after that, we need to think about other strategies. But yes, if furosemide is enough, there's other alternatives. David, I don't know if you have further comments about diuretics.
So, I tend to use torsemide very early in these people. What happens, not only does the drug not get absorbed, but and I think Dr. Havasi can comment on that, but as the right-sided pressures start to increase, it starts to choke the kidney a little bit and decrease GFR there. I teach my patients early on to monitor their weight very carefully. And when they start to gain 5 pounds, I tell them to take metolazone. Now, all this obviously depends on what their kidney function is, and you need to make sure that their kidney function is not the cause of this. Also need to make sure they're not any other medicines that cause leg swelling, like gabapentin, or for some reason somebody may be on amlodipine for high blood pressure or things like that. I think catching it early really is the key. Once you get behind the 8 ball, it's really hard to get back to baseline without hospitalization, and you really want to avoid that.
And just to add to it, I always say that the kidneys are fighting with the heart. They want different things. So it's really hard to get the balance right. And it is a fight usually, especially in advanced heart failure and kidney failure. And sometimes one of them loses out over the other.
All right, good. Thank you, guys. So Dr. Karam, I have somewhat of a long one for neurology.
And I'm sorry, I have to
Sure.
leave because I have to see some patients, but
okay.
Thank you very much. And I enjoyed it, and hopefully everyone learned a lot, and see you next time.
Thank you so much. And we also had to say goodbye to Dr. Dispenzieri. So we appreciate all of you giving us your time. Thank you so much.
Yep. All right. Okay. All right, so this patient says, I was diagnosed with AL and started chemo in March of 2016 with lambda of 63. During the course of the 3 years of no stopping chemo treatments till April of 2019. So free light chains are now in the range of 3. They took a break off. They took a break from April to November of this year, and now in 19, they resumed treatments with Polymelist and Elotuzumab. Really am struggling with these drug names. It turned out had a very bad reaction to the Polymelist. The treatment has been completely stopped for that drug, and they've been off treatment for a while. The light chains are still ranging in the 3s. And the lambdas. they've been on Velcade combined with some other drugs and had not experienced neuropathy during this period of time. But since April, after stopping the treatments, they're having more and more numbness and fingers turning white and total loss of feeling sometimes. And the question was whether the free light chain level that's been maintained around 3 since 2018. So could the free light chain at this level, could that be enough to damage the nerves, or could resuming some treatment improve the neuropathy? So, and let me know if you need to repeat anything.
No. So this is a common scenario. And of course it's going to be very difficult without a careful neurological examination, nerve conduction study, and so forth to try to understand what is going on. So first of all, I need to remind everybody that there are hundreds of causes of neuropathy. So just because you have AL and you got chemotherapy, it doesn't mean that you don't have vitamin deficiency or diabetes or some sort of other autoimmune causes of your neuropathy. So that is one of the challenges. The second problem is that sometimes once the nerve are damaged, people may experience numbness, tingling, pain, and the degree of these symptoms may change over time without necessarily meaning that the neuropathy is getting worse or getting better. So the symptoms themselves can vary, and that's why we really focus on function to kind of determine whether really there is progression of the neuropathy, as well as our neurological examination and all the tests that we could do. Regarding the hands turning white, that is usually not neuropathy. That could be something different, circulation problem, Raynaud phenomenon. It really depends on many different factors. And, your doctor needs to kind of ask you additional question. But to just summarize, I would be very worried if you're losing function. If you're able to, for example, climb stairs very easily. Now you have to use the handrail. You're able to walk fine without a cane. Now you need a cane or a walker. You're able to open the car with the keys, and now you need help with that. You're able to button your shirt and zip your and now you're unable to do those. So your function of the daily living are very important. And if there's decline in those, we really need to assess what's going on, whether there is neuropathy and progression of the neuropathy, and what is the underlying cause. Again, we need to rule out other reasons why people can have neuropathy, not just the AL.
Okay, thank you. Dr. Rosenbaum, another one I have here is this patient was not a candidate for stem cell transplant, nor could they handle the CyBLR-D due to GI involvement. And they are asking if it's possible that I can see a future with the CAEL-101 offered as maintenance type to keep the amyloidosis under control.
Without knowing the full history, it sounds like there's only been one regimen tried, the Cytoxan with Velcade and steroids, and possibly, and this patient is not able to get a transplant, but possibly no other treatments. And just backing up, there's so many good treatments we have that we in Dr. Dispenzieri's talk, started to highlight our now in this day and age, having responses to those treatments are really, putting us in, not yet, but in the range of hopefully where we'll see with some people's responses to transplants if they can continue them. But the GI tolerability issues that were with the Cytoxan Velcade, I would want to explore that more first, because especially Velcade and proteasome inhibitors are one of the best classes of drugs we have, and I would not would not leave that category until I understood they're actually differing GI complications with those two. Cytoxan is typically the agent that causes more GI distress, and that distress can be mostly loose stools, not like a mild nausea, and it's usually linked to getting the treatment, and it's comes for those few days, and then and then goes away, so it waxes and wanes, whereas Velcade can, in some patients, especially IV Velcade, when that was used more, cause very severe constipation, and that can lead to other GI side effects. So, you know, I would assume that it's more the former, because Cytoxan is almost universally at certain doses difficult for patients to tolerate to some extent. And then there's been a lot of more retrospective literature in the last few years, even questioning the value of Cytoxan in the regimen of upfront bortezomib dex, questioning whether that's even, how much is that really adding. The primary drug there is Velcade that is contributing to the response. So although we you know, Cytoxan can certainly be additive in some patients. So if it was more the former GI dysfunction with suspicious more for Cytoxan, I would certainly go ahead with the bortezomib. And if it was more that, there's a lot of ways to preemptively and prophylactically manage constipation. Doses can be lowered. And then Ninlaro, Exasamib, really has very minimal autonomic neuropathy and peripheral neuropathy compared to bortezomib, even sub-Q, much less. So that would be another option in that category. So these are common things, and they have to work with their hematologist. And then to answer for the KIL-101, the antifibril antibody, you know, unfortunately, these are just now starting in phase 3 trials. So hopefully they are positive. Certainly the initial studies, the very early studies, are very promising. And you know, hopefully they're positive, the larger trials for approval of it. But I think we're still at least a year or so away from approval. So I don't think we can count on that. And then as another caveat, that would not be used as itself. It's not used, it does not kill the plasma cells. So you have to, and I know the patient asked about maintenance specifically, but you have to use that at least if you're trying to still get a better response with another chemotherapy, at least in the studies, that's how they're being designed. And then for maintenance, there had been trials with NEOD looking at maintenance administration of that in once someone has already had their best response that the hematologist was happy with, and unfortunately NEOD was not approved. So perhaps there will be similar trial designs with KIL-101 looking at maintenance, but the initial phase 3 trials now are not examining that specific endpoint. So that will be probably even further away, unless it's in the context of the trial findings that they showed people staying on it helped, which they will be continuing in the trial to continue it monthly for long-term who are on that drug.
All right, thank you very much. Celestial, another question here. It says, are weight gainer shakes safe to use for patients, and maybe also the nephrologist, Dr. Abraham, it says, weight gainer shakes, are they safe to use for patients with kidney and GI involvement? So not necessarily for workout purposes, but just to put weight back on.
I'm curious to see what Dr. Abraham has to say. My viewpoint is no, not a weight gainer shake. That might have a creatine or other weight gain type supplements. That could be kind of a dangerous thing to do. For a protein supplement, if it's okay with what's going on with your labs and things like that, a basic type of whey protein is usually recommended. Or if your labs are altered, something like a specific type of collagen protein might be more helpful because it has less phosphorus in it. Like one brand is called Liquacel, Liquacel. There's another one that's called Prote Gold. Those are generally used in the kidney population, as they are a lot safer and don't elevate those other lab values as much.
I agree with. Go ahead, Celestia.
Oh, I was also going to address the issue of weight gaining, the reason for taking a weight gainer. I would rather see you work with a dietitian to find other foods that are safe for your kidney to gain weight with.
Yeah, that's an excellent answer, and I agree with all of that. In patients with kidney disease, typically we say not to overload with protein. We recommend a protein intake of 0.8 grams per kilogram body weight. I think need to be cautious about the protein supplements that you take, keeping in mind that you'll have to also account for the GI losses when you have GI involvement. And I hope that answers your question.
Yep. Yes, thank you very much. For back to cardiology. So here, the person talks about doxycycline. So they saw a website that mentioned doxycycline that might keep amyloid deposits down. And the patient mentions better NT-proBNP results, and it helped with the heart function and prevents infections. Her EF went from 19 to 60, her wall thickness from 20 to 40, and her NT-proBNP from 9,800 to 643. And the question is whether this is tried with good results for other patients. So either.
I'll go first.
Yeah, go ahead. Okay.
So I think this sounds like one of those television ads where somebody lost 80 pounds in 3 days. If it worked, that's really good, but the number of patients who've been studied on this is relatively small. On the other hand, the downside of using doxycycline in TTR amyloid, and I would imagine in AL also, is relatively small. The biggest side effect you have is, if you live in warm weather and the sunny weather, sun sensitivity to it. But certainly there's some data that it breaks down fibrils, that it may improve function. I don't know anatomically whether Dr. Picken knows anything about any change in pathology findings in patients who've taken doxycycline. But I think that's more than I think anybody should reasonably expect, although it won't hurt them.
Anything to add, Dr. Navati?
Dr. Picken?
Okay, I just
Picken,
unmuted
sorry.
myself.
Yeah,
I mean, it's a tough question. I mean, one would need to have serial tissue specimens, and there is no such data available. So the amount of amyloid which we can see usually poorly correlates with the function, and that's probably because what we see are mature formed fibrils, fibrillar deposits, and we are doing very badly in not being able to visualize prefibrillar species. So good question.
Yeah,
but no answers as yet. I'm sorry?
Yeah, I think the data is growing. The idea is to use doxycycline to try to dissolve the amyloid in the tissue. Mainly the data that I have seen is from Europe in some retrospective analysis, suggesting that it might help. I think there's a clinical trial, if I remember correctly, that is going on in Europe about it. And probably Dr. Kovacsovics from our team in Utah can expand more. I think he routinely puts patients with cardiac involvements on doxycycline, so he might have some insights about doxycycline on cardiac involvement.
Okay, so hi, thank you, Jose. So there are limited data, but what we can say at this point, the best data are coming from the UK. There was a retrospective study in patients receiving chemotherapy, and when they started chemotherapy, and they received really doxycycline, and the outcome of these patients was significantly better. But it's a problem with the retrospective trial and the historical control. So based on that, an international trial, but with only 80 patients, has been started, and we cannot participate in the US because of lack of funding. So we may get more information. In the meantime, what I do is in patients with severe cardiac involvement, I give doxycycline with the first cycle of chemotherapy. And I give it as tolerated For how long, it's a little bit unclear, but at least for 6 to 12 months, if possible. I don't think there is a role for later really administration, and somebody asked a question really for maintenance. So I tried early on with patients really with severe cardiac involvement because their prognosis is relatively poor. And as Dr. Wolinsky was mentioning, there is not too much of a downside to the use of that medication. But I really use it not as often as Jose thinks, but really, I think it is worth it when the patients really, again, have a poor prognosis.
But if you administer chemotherapy plus doxycycline, how do you know what's the effect of chemo versus doxycycline? Just by comparing the groups with and without?
In the long term, that's what we would like. I mean, here, with patients with advanced heart disease, we know that I would say the question is, can they survive more than 6 months? If they do with a reasonable response, we do better. So what I hope is that to try all the supportive care measures which we have available, and the main ones outside of chemotherapy are really cardiac medications, diuretics, etc. And if I can add doxycycline, why not? But it's really something secondary compared to chemotherapy and really the cardiac support.
Thank you, guys. Yeah, thank you. Good discussion. We may have time for maybe just one or two more. I have one now. This is actually for anybody, any of the physicians. It's about the chemo and menopause. So, menopause can be a side effect of CyberD or, of course, a stem cell transplant. This patient was not aware of that. They kind of, came upon the information and learned about it after, of course, started occurring. And the question is whether or not an OB/GYN care is OB/GYN care normally recommended as follow-up for women on chemo? And as recommended by this person's nephrologist, I know I need to see my OB/GYN for bone density tests, and then wants to know why there isn't a more holistic approach for treatment. And are CyberD and Velcade treatments the only ones that cause menopause as a side effect? And is there an equivalent hormonal response for men?
Well, let's start this one off with Dr. Rosenbaum. Let's see what you have to say on this.
I think that's a great question. I think at least hematologists who treat plasma cell dyscrasias, myeloma and amyloid, it's not in our first, at least from the symptoms of menopause. And if for instance, if someone, needed ovarian preservation and wanted to have children, it's not the first thing in our minds, mostly because the average age of a patient with AL amyloidosis is 63, a little younger than our myeloma patients, but already postmenopausal. But of course, that's the average, so half the patients are under that age. And I think the two parts that issues that the patient's worried about, ability to cause menopause, and also then the effects of menopause on bone density, symptoms of menopause. For myeloma, we do work very closely with endocrinologists studying bone density. And luckily in amyloid, just the nature of the disease, it doesn't affect the bones similarly to myeloma. It doesn't weaken the bones as much. However, certain chemotherapies can have effects. So I think a general answer, because there's a lot to kind of put in here, and we can't go through every single side effect of every single chemotherapy used. I think that if there's a concern and a patient is pre or perimenopausal, I would certainly work concurrently with the patient's gynecologist or refer her to a gynecologist. And similarly, if there's concerns with bone density, with an endocrinologist.
Anyone else have anything to add to that? No.
I have, Dr. Karam, I have another neurology one. So this lady's husband has AL with kidney involvement and had a stem cell transplant in 2017 that did not work, and then Velcade that did not work, and now is on DARA for a year. And it says, we realize that the amyloid will not be cured and the DARA is just keeping the amount of protein lower in his system. Yeah, and the real problem is the peripheral neuropathy in the legs and feet. He is also experiencing balancing issues and getting worse, not holding steady or getting a little better as they were hoping after a year of DARA. Is there anything he could do to help with the healing of the coating of the nerves? Is there any kind of brain training that can be done to help with the balance and overall alertness? Are there any kinds of, also a question about diet, maybe for Celestial? And he has tried physical therapy and it did not help. And anything you can recommend. So.
Yeah, again, I would like to repeat that always work up the reason why there's neuropathy before we blame it on amyloid and the chemotherapy. However, in his situation, it may, unfortunately be related to the amyloid or the chemotherapy or a combination of both. So at that stage, the question is the neuropathy getting worse or is it stable? If it's stable, it's usually a very good sign because we can try to work around it to kind of manage the problems and interfering with the daily living that it has caused. So in regard to the balance, people don't like to hear me say that, but I always suggest using a walker because it really is the best thing to prevent falls. I've seen a lot of people fall, break their hip, break their wrist, or even had, a head trauma because of the fall. So fall prevention is extremely important. For the pain symptoms, we discussed different medication. There are different options that we can use. Overall, unfortunately, there's no magic pills that we can give. But again, looking for if there's any sort of vitamin deficiency that we can supplement. Of course, healthy diet is important, and I'll let Celeste talk about this. I don't know if I answered all the part of the question. Was there something that I missed?
No, I think that's good. Yeah. Celestial, anything specific? We talked about other nutritional, but maybe specific to neuropathy or anything?
Yeah, gosh, I wish there was a magic bullet for this, for neuropathy and nutrition. There just isn't, except for kind of what I've been saying, a healthy diet. With neuropathy, one thing that can be helpful is if you are having swelling also, is to reduce your sodium so that you're not having swelling kind of exacerbate symptoms. And then there is some research on making sure you're getting good healthy fats for maintaining your overall health. But as far as magic bullets, there just aren't any for neuropathy.
So I have a question to Dr. Karam. There is a new or an old drug which has had sometimes some amazing activity in patients, but I'm not sure it's real or not, alpha-lipoic acid. Could you comment on that because it's easily available? And
yes, unfortunately, the data to support the use of alpha-lipoic acid is not present. So the studies that were done are negative. However, it's a supplement, it's over the counter, and there's no side effects that I'm aware of. And I've had patients who have tried it and swear by it, and other patients who've tried it and it didn't work. Whether it's a placebo effect or nothing, or a real effect, I don't know. But at the end of the day, it doesn't really matter. If the patient is feeling better, that's what's important. So I do support people trying it for a few weeks and see what happens, especially that it's a relatively safe supplement and it's over the counter, so they can go get it from any pharmacy. And if it works, great. If it doesn't, we can still try something different. But yes, thank you for reminding me of this. So alpha-lipoic acid, you can find it online or in any of the pharmacies over the counter.
Do you use it more for existing polyneuropathy or for patients receiving chemotherapy such as Velcade?
So I've seen people use it mainly when they develop the neuropathy, whether it's related to chemotherapy or whether it's inherited neuropathy, so or diabetes, so all type of neuropathy. Some patients seems to maybe benefit and really swear by it.
Okay, thank you.
We had to say goodbye to Dr. Wolinsky. He had some patients waiting, and I guess we have to let doctors go so they can see their patients, right?
Yep.
And I did put a link down on the chat to a presentation that Janice Wiseman had done for us at a meeting that really seemed to go over well, and it listed a bunch of things that you were talking about, Dr. Karam. So, people can feel free to copy that link and paste it somewhere so that they can look at it when they have a chance to, okay? How many questions we have left, Tracy?
Oh, we've got about half done. So we made it through about half of the 50. Actually, less than half.
Okay, so why don't we do this, because I think we're losing doctors and we're probably going to lose attendees, too. So why don't we do this? We have you save those questions, and we've got questions on the Q&A icon that have not yet been answered. We'll ask Bob to say and Paula to save those. And we will send all those questions to all of our doctors that were here today and let them answer it when they have time. And then we can put the answers up on our site when we put up the recording, okay?
Yep.
And we just want to say thank you to everyone. This means so much to so many. You know that. The emails that we get after these events, it's enough to make you cry. You just feel like, you just don't know how much you're affecting people's lives. It's life altering what you're all doing for us. And we really, really appreciate it. So we're going to thank all of you, and we're going to thank all of our attendees for coming, because you can't have a party if no one comes, right? And Bob and Paula will make this available on our website. We'll put questions up with the answers on our website. We'll announce future schedules on our website under the webinar link on amyloidosissupport.org. We'll also announce it on our Facebook groups and emails and One Amyloidosis Voice and any other social media we can find. It'll let us post it. And does anyone have any final words to say before we bid everyone adieu? Well, we thank you all so much.
Thank you.
And we'll
Muriel, do you want to, there was a question about the ATTR. Do you want to address that?
What was the ATTR question?
They asked if there was something similar for ATTR. I think.
Right. We have an ATTR meeting.
Oh, I answered that.
Yeah, we have an ATTR meeting coming up in August. I know there are a few of you out there that have the bad enough luck to have AL and wild type TTR as well. And we didn't address that today, but we will, we'll address that in August when we do our TTR meeting. And so, and our next AL meeting, we will let everyone know probably in September when that will be, okay? Whether it'll be live, face-to-face, we'll be live on the webinar. And again, we'll have a whole bunch of new doctors and some of the same old faces that you're seeing now. We like to mix it up. And oh, Bob's smiling when I say same old faces. You're not that old, Bob. Okay. So we'll see you all soon. Take care, everyone.